Good day, folks. Alfie Vente here once again at Vente Pain Relief Clinic and VPRC.ca. I'm hoping you're having a great day. Today, we are on our soft tissue case study, Take a Hike Pains Part 2. So hopefully you did Part 1. This is our answers and discussion. This is a thoracic outlet syndrome case. Basically, that's what this case is about. If you had a chance to watch the video, the first one, hopefully you had some time to think about the answers to the questions that I've asked. So now let's get on to the case. So just to rewind, this is a thoracic outlet syndrome definition by the Mayo Clinic. So thoracic outlet syndrome, TOS, is a group of conditions in which there's pressure on blood vessels or nerves in the area between the neck and shoulder. This space is known as the thoracic outlet. Compression of the blood vessels and nerves can cause shoulder and neck pain. It also can cause numbness in the fingers. So here is an illustration here of the definition that I just spoke of. The neurovascular bundle is in that red circle. You see the cervical spine there. It's a cutout of the front. Just to sort of give you guys a review of the neurovascular bundle and where it sits anatomically. So as a review, here's the case study. Your patient client is an avid hiker who is currently suffering from pain across the right clavicle to the bicep, into the medial border of the scapula of the right side, and referral pain down the right arm into the hand. He mentions to you that he recently returned from vacation and had been hiking daily for miles at a time for a couple of weeks in one of the national parks. He states that he thinks that a large part of the reason is that he had been hiking with a 50-pound backpack every day at 5 miles a day. He is decently fit and works out. This is his first time doing this sort of hike. His hikes are generally over a weekend, and typically his frequency is at least 2 times a month. This is also the first time he has noticed referral pain down the arm. So this is basically a big jump, an increase in volume to what he is accustomed to. It is low throughout the day. We're talking about the symptoms themselves, the day, but there seems to be certain motions, activities that exacerbate his condition. For example, when he attempts to wear his backpack and after a long, hard day working in front of the computer as a computer engineer, symptoms seem to spike. So we're going to go into the key observations, but I just want to ask you guys, if you like our content, please like, share, subscribe, pass this on to those that you feel this might be helpful for. We want to thank you way in advance. And if you're on YouTube, hit that notification bell. I also encourage any instructors that feel that this might be helpful for students to pass this on. We really would love it if you did that. And again, we thank you in advance. So now, on to the key observations. The patient client has a kyphotic posture with a forward head position. Right shoulder seems more medially rotated. Tipping or tilting of the right scapula observed when patient client is in prone. And we're specifically talking about the inferior angle of the scapula. Forward flexion of the neck to the right side causes pain locally and down the arm. So this is the scaling cramp test. Whenever they do this towards the right side, they notice that the symptoms seem to increase. More of the key observations. Special tests, military brace, aka the costoclavicular test, Eden's, Adson's, and Wright's hyperabduction show positive. When head and neck are flexed to the unaffected contralateral side, in other words, towards the left, it causes pain locally of the right neck on the lateral side. Pinpointed palpation into the right scalenes triangle causes local sensitivity and pain down the arm. So when you're pressing into this area here, there seems to be some referral symptoms. Pinpointed palpation just inferior to the right clavicle elicits radiating pain inferior to the clavicle and extends towards the bicep. So that's a very important key observation. So let's talk about what we're talking about, the scapular tipping, tilting of the inferior angle. So this is when the person is lying prone. You will notice that the inferior angle kind of tips off the rib cage. And the reason for that, this is my little schematic here for you guys, is that you see on the first picture there, that's a picture of the of pectoralis minor. And the arrows pointing to how the direction of pull of the pectoralis minor, pulling on the coracoid process when it's very, very tight. You add on to the weakness of the lower trapezius of the second picture there, and it equals a tipping of the inferior angle of the scapula. And because the lower trapezius is having a difficult time stabilizing the scapula there, along with the tightness of the pectoralis minor, you get that position of the inferior angle of the scapula. I call it the garage door effect. So think about the garage door pulling, like this, if you have a cable, pulls on the garage, it pulls it up. This is kind of a similar visual. So the critical thinking questions that I had for you guys to think about over the week or so is, what do you think is the root of your patient client's issues? What are 3 muscles that are potentially implicated in this person's condition? Describe the mechanics of the 3 special tests, military brace, Addison's, and Wright's. Why would there be a pain response when your patient client flexes their head to the opposite side? So those are the 4 questions that I had asked last week. So now let's get on to question number 1. What do you think is the root of your patient client's issues? So basically, the root is the increase in volume relative to their regular routine of hiking. This is with hiking with the weight of a 50-pound backpack. I think this one was a no-brainer. I did mention that this was a Thoracic Outlet Syndrome case study. Over time, the posture has caused changes such as shortened muscles that have potentially impacted the neurovascular bundle. It has also decreased the space between the clavicle and first rib, putting pressure on the neurovascular bundle. And that goes along with one of the special tests that I had mentioned earlier. Going back a second here. Question number 2. What are 3 muscles that are potentially implicated in this person's condition? So for sure, pectoralis minor, scalenes, and subclavius, potential subclavius trigger point. We're going to talk about that in a bit. To a lesser degree, the lower trapezius, as mentioned with the scapular tipping, scapular tilting diagram that I showed earlier. With the weakness of the lower trapezius, you're going to get that tipping or tilting of the inferior angle. Number 3, describe the mechanics of the 3 special tests, military brace, Addison's, and Wright's. So for these mechanics, I tend to use Orthopedic Physical Assessment by David J. McGee. The diagrams, this is one of my favorite textbooks to use. So if you have that, you can flip through the references that I mentioned there, that's mentioned there on the page. So for the military brace for costoclavicular syndrome, this generally happens when people are wearing heavy knapsacks. What happens is that the clavicle and first rib decreases in space, causing an issue with the neurovascular bundle. It gets pinched underneath that. So because this person's wearing a heavy knapsack, and again, like they've increased their volume with their activities, potentially it's caused this positioning of the clavicle and first rib to be more closed in together, pressing on the neurovascular bundle, causing the issues potentially down the arm and into the chest area and shoulder. So you can see here, with the McGee picture there. The therapist has, just like with all the thoracic outlet syndrome, I'm pretty sure all of them have this. They're palpating the radial pulse, pulling on the arm, and basically what they're doing is they're drawing the shoulders down and back, right? So they're pressing down so that the clavicle and first rib pretty much get closer to each other. And what the therapist is looking for is if the pulse diminishes or if the person notices that they're getting symptoms down the arm. That's a positive sign for this. It might take a few seconds before anything shows up. So you want to hold that position for at least 30 seconds to a minute or so to see if any of the positive signs show. So that's the military brace or costoclavicular test. I think it's also called Eden's test. So for the costoclavicular test, I also want to add that there could be a subclavius trigger point. Actually, there is with the case study. The subclavius trigger point is basically underneath the clavicle and it goes out into the bicep. So if the person's noticing that they've got pain, and remember, a trigger point is more muscular in origin, so the muscle itself has these points that can cause the pain, the referral pain into the just underneath the clavicle and into the bicep. Generally, if you palpate just inferior to the clavicle, you could elicit that the pain response down into the bicep. And I think I mentioned that in the case study. ADSENS for scaling syndrome. So it looks similar to the military brace test, and basically this one's it's testing for any compression on the neurovascular bundle where the anterior and middle scalenes meet. If they're very tight, it can basically press on that structure there, causing pain down the arm. So just like the costoclavicular syndrome test, the therapist is palpating the radial pulse, pulling the arm back, and getting the person to actually rotate their head towards the side that they're pulling the arm back. And what they're looking for again is a diminishment in pulse and potentially symptoms down the arm. That is a positive sign. Again, you want to wait for a few seconds, 30 seconds to a minute. Generally, when I do this test, what I'll do is I'll get the person to take a deep breath in also, basically getting the scalenes to actually work to shorten as they breathe in, potentially causing more of an irritation to the neurovascular bundle if they do have the scaling syndrome. And finally, Wright's test, Wright's hyperabduction, Wright's for pectoralis minor. So this one is basically if the pectoralis minor is very, very tight and pressing on the nerves and blood vessels. This one here, you have the arm raised up to about 45 degrees. Again, the therapist is palpating the radial pulse to check to see if the pulse diminishes or if they're feeling, the patient's feeling any symptoms into the arms. That's a positive sign also. So with this one, what it's doing is, let me just pull up the next picture here, is that because the pectoralis minor is very, very tight, you're basically putting it on a stretch position here. If it's short, if it's very short, it'll cause that muscle to become very taut and basically press on the neurovascular bundle there, causing potential issues down the arm, giving that positive. And also the potential diminishment of the pulse if they have pectoralis minor syndrome, if their pec minor is very, very tight. So question number 4, why would there be a pain response when your patient client flexes their head to the opposite side? So the answer to this is the scalenes on the affected side is very short and tight. The symptoms become exacerbated because the muscles are shortened and potentially has decreased flexibility. So in other words, if this is very tight on this side and I'm pulling this way, it can cause an irritation because that muscle is already very shortened and you're putting a stretch on it. That is question number 4. So there you go, folks. What was your theory? What did you think in regards to how you came about to your conclusion? With this case, it seems to be fairly basic, but if you've got other ideas, feel free to comment below. I'd like to hear your thought process. I want to, find out what people are thinking, and again, we really appreciate that. Thank you for watching. Again, you can please follow us on our social media. You can also visit us on our clinical website, ventepainrelief.com, and also we have our pain relief fitness website, vprc.ca. Please like, share, subscribe, and again, pass this on to those that you feel this might be helpful for, and ring that notification bell if you are on YouTube. We really appreciate it. My name again is Alfie Vente of Vente Pain Relief Clinic and vprc.ca. Watch out for our upcoming case studies, soft tissue case studies. Again, these case studies are not just specifically for massage therapists. They're for any type of therapist. They're designed so that like a chiropractor, a physiotherapist, physical therapist can actually do these case studies and access the skills and knowledge that they've gained over time in regards to working with the soft tissues, muscles, and fascia. Thank you again, and we really appreciate it. We'll see you in our next video. Have a great day. Take care.